Putter är. Han får det. तुम CNS में सुन लो CNS YouTube पे रखो
and my grandmother. Next slide, please. On the side of the road, I was resuscitated because many facial fractures. I lost the right eye, and I also had a neck and back injury, and taken to the high care unit and kept there for about a month until I was able to be discharged. Next slide, please. So this is a snapshot of a 9-year journey. Even though I had all those other injuries to me, the most complicated were to my face. And so I needed to have different prosthetics implanted. Next slide, please. In my 6th year of surgeries and my 4th prosthetic, I went out shopping one day. I came back to the car and I felt moisture on my face. And when I pulled down the rearview mirror, I saw this pus seeping out of the cheek prosthetic. And I called the doctor and I said, what do I do? He said, you need an emergency surgery. This is an infection. So we did the emergency surgery, which was to debride the prosthetic. But 2 weeks later, the infection came back again. So we did more surgery, but 2 weeks later, the infection came back again. I was then under the care of different types of specialists, so ENT surgeon, ophthalmologist, plastic surgeon, maxillofacial surgeon, each of them prescribing antibiotics, doing surgeries, until 11 months passed that this infection had still not cleared. Next slide, please. So at that 11-month mark, they removed the prosthetic in an emergency surgery and sent it for testing. That was the first time I heard the word test, and so I phoned the pathology of that. Along the right-hand side was a group of R's and S's, and at the top read the letters MRSA. And like any other patient that wanted to know what is happening to their body, I went onto the internet and I started to try and understand what that meant. And up came antibiotic resistance. As you can see on the left-hand side, that was all the damage that had been done by this flesh-eating bacteria. I could hardly keep an artificial eye in, and I had to cover my face. Things like I'd go fetch my child from school and the children would be quite scared of me. So next slide, please. So in desperation, because it felt like my doctors had now given up hope, we had to get to fix that damage, we had to do it in as few surgeries as possible. So I reached out to a craniofacial surgeon in the USA, and he gave me some advice over a video consultation, which I took back to a maxillofacial surgeon in Johannesburg. That was to cut the bone and realign it. And unfortunately, even though aesthetically it looked good, next slide please. The infection came back again, this time even worse, all over the face, in the skin and at the bone. So my doctor then rotated antibiotics, and slowly but surely over a 4-month period, very close monitoring and working with him, the infection finally cleared. Next slide please. So in my first slide I said that was my last photo. I avoided cameras for obviously that whole 10 years. It was very difficult to look at my face in the mirror watching this infection eating the skin away. This was some of my first photos after that 10-year period where I felt confident enough to show my face to public, Next slide, please. So the work that we have gone on now to do, I've been an advocate for the last 11 years, and most recently we've established the WHO Task Force of AMR Survivors. I've just shared my story with my one face, but this is about the many different faces of AMR. We're made up of 12 members with different unique stories. Next slide, please. And one of our biggest objectives, or some of our biggest objective, is to obviously bring the human impact, to move beyond the science and the numbers. And for several reasons, because when policy makers understand exactly what that is, and members of the public understand exactly what that is, we can break down, we can empower them. One of the documents that we've just worked on, and I'll end now as well, is the Strategic Technical Guidance Document for Meaningful Patient Involvement. So I would encourage you to go take a look at that on the WHO Task Force of AMR Survivors website page as well. So thank you.
Thank you so much, Vanessa, for your moving testimony, but this is what to go through. Now we're going to Professor Ramanan Laxminarayan, who has been working on this issue for many years. He's the president of One Health Trust and also the chair of the Global Antibiotic R&D program. But also this week, a special issue of the Lancet on sustainable access to effective antibiotics was launched by him. So over to you, Ramanan.
Thank you, Peter. Thank you, Dr. Tedros, for the invitation to speak. Excellencies, friends. All of you have heard about AMR. Sometimes it's a bit obscure, but the real issue is of sustainable access to effective antibiotics. That's really what the problem is about. Because we have to remember that lack of sustainable access to effective antibiotics kills more people than AMR does, right? So the Lancet series, I've left some infographics at the back there for you to pick up on your way out, but I want to remind you that the problem of this access is seen as neither urgent and it's seen as too difficult, and neither is really true. It is urgent because it kills more people than HIV, AIDS, and TB put together, and malaria put together. It's absolutely addressable using tools that we already have: water, sanitation, hygiene, IPC, immunization, and better access to existing antibiotics. So this is a problem that can actually be solved. Since the high-level meeting in 2016 in New York, we've made progress on many fronts. I think the setting up of the AMR division here at WHO under Dr. Tedros' leadership has facilitated progress on many fronts: guideline setting, surveillance, national action plans. But critically, it has facilitated intersectoral coordination with other UN agencies, FAO, WOA, and UNEP. And in effect, this work on AMR has set the stage for One Health, which is, you know, a complex word in some ways, but it's a very simple and ancient recognition that our health is inextricably intertwined with the health of animals, the planet, and the plants. That's all it really is. Now, the 2016 UNGA Declaration objectives, where we have performed, including on setting up the IACG and creating national action plans, were very specific. In other words, where we were specific, we have succeeded. Where we have been vague, we have failed. That's really the lesson, not just from the 2016 UNGA meeting, but also from the Millennium Development Goals, from the Montreal Protocol, from indeed any international agreement where we've been successful, all of which have 4 elements. They have political will, they have specific measurable targets, they have funding, and they have governance and accountability. Now, we clearly have political will, otherwise all of you would not be in this room. Now, we need to hold the world to measurable targets and then find the funding to reach them. Now, the Lancet series, which was kick-started at the African Union, launched earlier this week in Geneva, and represents the best science and expertise in the world, calls for 10, 20, 30 targets. Basically, it's a 10% reduction in mortality in humans, same as what the GLG has called for, a 20% reduction in inappropriate antibiotic use, but against a backdrop of universal access to WHO's access antibiotics, and a 30% reduction in antibiotic use, inappropriate use in animals, which is again very achievable because WOA has reported that there's already a 17% decrease in the last 6 years, so another 13% is not really that hard. So these targets are achievable using currently available tools, many of which are already funded. They're supported by science and evidence. They hold us collectively responsible for progress before 2030, when the SDGs are also due. The Lancet series, as you heard from Prime Minister Motley, also calls for the establishment of an independent panel for evidence on antibiotic resistance and access. Access is very important to ensure that the best science and policies from around the world are shared. Now, friends, each year, 7 points because of bacterial infections, 7.7 million. Only these infections can be prevented. Many can be treated with cheap antibiotics that have been available for a long time, but are still not reaching patients in need in many LMICs. And many of these patients will also need new antibiotics, which have to be developed, incentivized, but even those may never reach patients in need unless we plan for this to happen. The Lancet series calls for existing global fund agencies that are already in this city to create an antibiotic access fund that can ensure that existing and new drugs are available and that they're available to patients in need in LMICs. All of this will cost much less than what we spend on other disease conditions with much lower disease burden. The UNGA high-level meeting in September gives us a great opportunity to act. The targets, the call for funding, independent panel are all already in the zero draft, this excellent zero draft that Barbados and Malta have produced. We can build on this to make sure that we produce an actionable document that can produce results within the next 3 years. I think of AMR as an optional crisis. Unlike with other pandemics where we're at the mercy of other events that are outside of our control, dealing with this one is entirely in our hands. We can and should ensure that no one anywhere suffers or dies because of lack of access to effective antibiotics. Thank you.
Now it's, thank you so much, Raman, and with some concrete proposals now, great pleasure to introduce Professor Dame Sally Davis, friend, and you've been really one of the most important global voices on this. Over to you, Special Envoy on AMR for UK.
Thank you very much, and I want to start by thanking you, Director General, for setting this up. Always important, but particularly in this year with the high-level meeting. And Vanessa, I've heard you speak before. You are always very moving, and you bring the reality into the room, and I admire how you manage to do that Thank you. Let me bring into the room the 1.3 million people who die every year of AMR, the 5 million who die where AMR is in their bodies and it contributes to it. Let me remind you that children, particularly under 5, are particularly vulnerable, as are the elderly. Just think about the demographics in many of our countries and how more and more people are going to be more vulnerable to this. So let me too congratulate Prime Minister Motley for her leadership, and actually Barbados and Malta for their political leadership in co-facilitating this quite complex process. They've produced a zero draft that really gives us strong foundations for negotiations. We all want this high-level meeting to be action-focused and outcome-focused and give a roadmap for the way ahead. But as we move forward, we're going to need implementation discussions, so I welcome the Kingdom of Saudi Arabia 4th Ministerial Meeting aimed at just this in November. I think it's great to see that we've got several core priorities that many have called for in that zero draft. Prevention, many of these Ramanan has picked up, access, but also governance, accountability, and One Health in this draft. It is not the One Health, as some people say. It is a One Health because we all have different One Healths around the place. And also, for the first time, a commitment to establish a global independent science panel. The UK position is we ensure that the high-level meeting, which is on AMR, so that has to be the focus, truly addresses the needs of the most vulnerable communities, offering clear support to low and middle income countries who, after all, carry the greatest burden of this antibiotic emergency. So we've consistently called for fair and equitable access to antibiotics and diagnostics to be a high priority. Better access to essential antibiotics combined with an improved pipeline of new antibiotics and diagnostics will save millions of lives to come. And it needs to be embedded in a better system of WASH, IPC, vaccines and prevention with responsible stewardship. We from the UK are also calling for existing international financial instruments to be made available to support AMR interventions. There is money available, but most countries don't know what's available and find it too difficult. Our financial institutions, led by the World Bank, who've just published an excellent AMR framework, need to make it more evident and more easy to get that money. We convened a meeting recently in London on the 16th of May with global leaders from all sectors and many countries, and we from the UK have pledged support with funding for these priority areas. And this includes the panel, which is going to need to be truly independent, multi-sectoral, strong representation, and I hope strong leadership from the Global South. We've got to support each other as states and as groupings, sharing updates, evidence and best practice. And actually, we believe there is a strong need and desire for a voluntary monitoring and reporting framework, and we've got to back up the actions that member states commit to. We also want to strengthen the quadripartite structure, perhaps a rotating chair, but formalise it. But the reality is the best drafts are only drafts, and it is the collective responsibility of all of us to ensure key commitments to prevention, access, a panel, strengthened accountability, coordination, governance, access to finance. All of those things we know are going to be important for saving lives going forward, are preserved and strengthened as we go through these negotiations. If we do that, we can get a clear pathway from declaration to implementation in November. So we're going to be working with the co-facilitators, the international community and partner countries to really look closely at the declaration and ensure, as far as we can, that it steps up to these, our shared ambitions. So I'm going to conclude. No surprises here. I'm calling on everyone to make equity, One Health and action the cornerstones of our next steps to tackle AMR. And I'm looking forward to working with all of you over the next few months. Thank you very much.
Thank you very much, Sally, for not only being a great champion, but also have been very action and implementation oriented. May I now ask His Excellency Dr. John Kaseya, the Director General of the Africa Centers for Disease Control and Prevention. Thank you very much, my friend.
Thank you, Peter. Please let us be led by data. Based on Lancet that was released in 2022, over 1 million deaths in Africa were associated to AMR and 250,000 directly linked to AMR. That is almost 20% of the statistics that Dr. Tedros was sharing with us. But please let me be clear on that. Because we know, based on the studies that Africa CDC released on 2023, that only 1.3% of our labs in Africa are able to perform bacterial resistance testing, it means this data that I'm sharing with you is an underrepresentation of the reality in Africa. In 2020, the AU African Union Assembly decided to establish the AU-wide task force to control AMR. And it was a recommendation for all member states to put in place a strong national action plan to respond to that. But let me share with you, today we have less than 10% of our member states that have national action plan that is fully funded and implemented. We know that people in Africa are mostly dying, as Ramanan said, due to lack of antibiotics. But when we want to talk about AMR, it's mostly driven by fake medicines. I was talking with the minister of DRC, was telling me 80% of antibiotics in DRC are fake. It's also led by the irrational use of antibiotics, poor food security and water sanitation hygiene conditions. We applaud the initiative of the high-level meeting in September in New York. Africa CDC, we will do our best to bring a number of our head of state to attend because we need a strong political commitment. This strong political commitment will unlock not only the National Action Plan, but also appropriate domestic resources to start to target this AMR. We agree, as Ramanan said, on the target of 10, 20, and 30, because that one will be our motto and our objective for the next 5 and 10 years. Today, in Africa, we consider that AMR becomes a major vehicle for the universal health coverage because it's targeting all pillars of the health systems in Africa, including sustainable financing. Let us talk about financing. Yesterday, I had a meeting with a number of partners, and I'm calling for the extension of the mandate of Global Fund, because Global Fund, they are using TB to target AMR. I'm calling today officially to expand the mandate of Global Fund to become Global Fund against HIV, TB, malaria, and AMR. And Africa CDC will work together with all partners, and I thank Sally for the initiative that you took, with all partners to provide appropriate funding to tackle AMR with this initiative we are calling today. We'll work to reinforce availability of quality data, because that one will help us to lead for appropriate decision by reinforcing the surveillance and the lab systems. We'll also reinforce the community engagement, because we need people to have appropriate information and to stop the irrational use of antibiotics. Lastly, we are calling to accelerate the agenda of local manufacturing in Africa, because we want all Africans to have access to quality and affordable antibiotics when they need it. Thank you.
Thank you very much, Jean, for highlighting a number of issues and, again, some very practical proposals, and also highlighting the manufacturing. Now, our next speaker, it's my pleasure to ask Dr. Abdullah Aghvizani, who is the CEO of the Public Health Authority of the Kingdom of Saudi Arabia. Thank you for being with us and for hosting the next ministerial meeting. Thank you.
Thank you very much, Peter. Dear Director General, honorable guests and delegates, it's a great pleasure to be here today. And I would like to thank you for inviting me in this round. And Vanessa, thank you very much for sharing your story and your bravery in this, with your story. I would like to emphasize the concept of the health and all policy that we are embracing in the Kingdom of Saudi Arabia. And we have made health a part of, a significant part of the Vision 2030. Under leadership of the custodian of two holy mosques, King Salman, and His Royal Highness, Prince Mohammed bin Salman, Crown Prince and Prime Minister. In Saudi Arabia, we have implemented an effective cross-sectoral governance for a framework for AMR. There is an urgent need to have more accountable, effective, and functional multi-sectoral governance system in place to coordinate the local, regional, and global response to AMR, and also successfully implementing targeted interventions. We are working with the global leader group and the Quadripartite, and with a number of member states who share our sense of urgency in uniting around a set of urgent practical measures to tackle growing threat of AMR. In this critical year, we need to stay focused. We need convergence around limited number of action which can be approved at high-level meeting. It is in our intention to take the declaration from New York in September, and in the consultation with the Quadripartite and other countries, turning into a very concrete action in Jeddah in the 4th AMR Ministerial Meeting, under title From Declaration to Implementation. Please let me reinforce the ambition of the Kingdom of Saudi Arabia to make the 4th Ministerial Summit an inclusive forum to which all of you can contribute. In this context, we will be announcing a series of innovative and practical outcomes, aligning with the Saudi Vision 2030, which will support country and partners in implementing their cross-sectoral AMR National Action Plan. Also promoting stewardship, building capacities, and support effort to improve access of antimicrobial in the region and beyond. Thank you.